Hi, my name is Jerry Hesch. I'm a physical therapist and I work at the Hesch Institute in Henderson, Nevada, which is very close to Las Vegas, Nevada. And this is a poster presentation that was presented in October of 2013 at the American Academy of Orthopedic Manual Physical Therapy conference in Cincinnati. And the title of this is Pubic Joint Dysfunction and Symphyseal Diastasis, which means rupture and separation, a novel biomechanical and treatment model. This is part one, and I will read it verbatim. Pregnancy and birth create widening of pelvic joints and birth canal in response to ligamentous softening and fetal growth. This process can lead to mild to severe pelvic joint pain. Pubic joint dysfunction describes a painful condition of the pubic joint with less than 10 millimeters of separation or widening. Traumatic symphyseal diastasis, such as from falls or a motor vehicle accident, is a much greater separation of the pubic joint. Obstetric pubic symphyseal diastasis involves severe pain and impaired function with separation of the symphysis pubis of 10 millimeters or more as identified with X-ray, CAT scan, MRI, or ultrasound. And figure 10 demonstrates widening there. If we can zoom in there, you can see that there's a significant widening. The yellow arrow points to the widening of the pubic joint. And I can demonstrate that on this mobile pelvis also. So this is the pubic joint. And this has a little bit of modification. We're using it for a research project. Basically, it's a widening, a separation of the pubic bones. Obstetric pubic symphyseal diastasis is the focus of this presentation. It is noteworthy that only a small amount of pathological anterior sacroiliac widening occurs in the presence of an extreme separation of the pubic joints, as shown in figures 3 and 4 and 8. So in this picture, this is an X-ray, and it's a little bit dark, but there's considerable separation of the pubic bones here. And this is the very same patient. This happens to be a CAT scan that was taken on the second day. And this person, this was a birth trauma. She was delivering a baby and this joint separated. And at the SI joint, there is a little bit of widening, but this is measured only on the order of a couple of millimeters, whereas the separation up here was 47 millimeters. We'll get to the other figures later on. Obstetric pubic symphyseal diastasis is not well understood, and chronic patients do suffer very much. As one author stated, the persistence of symptoms in our patients emphasizes the need for careful examination and follow-up of these rare injuries. The outcome in our patients was poor, and results in the literature are equivocal. A novel theory is presented with this poster, which suggests that obstetric pubic symphyseal diastasis joint mechanics are distinctly different from that of a normal pregnancy and birth joint mechanics. The purpose of this poster is to bridge knowledge from the orthopedic trauma literature, propose a new biomechanical model based on unreported findings encountered by reviewing images, and to discuss novel treatment. Orthopedic manual physical therapists perhaps have much to offer the non-surgical population who suffer from pubic joint dysfunction and obstetric pubic symphyseal diastasis. And we'll now talk about evaluation, and we'll talk about stress test imaging for occult instability. Passively stressing the pelvis, pushing on the ilium on one side in a posterior and lateral direction, while taking comparison x-rays is a relevant, although underutilized screen for acute surgical instability. And several authors have written on this test. This test has utility in the acute phase because there's considerable recoil that occurs right after the traumatic or obstetric pubic diastasis. And what they're basically saying is that when someone sustains, as you see in this image here, when someone sustains a trauma in which there is a severe separation, very soon after, the bones actually do come back together. And if you take the x-ray and the bones have come back together, you look at the width of the joint and you might decide, that that's fairly normal, that it's not a significant injury. What these authors are stating is that in that example, when you take the x-ray while at the same time imparting a stress through the hemipelvis or through the ilium, and you see a significant gapping, then you know that that is in fact a severe instability. So we have to go beyond looking at the width of the joint. In this example, it was very obvious. But again, you may have other examples in which you take an x-ray and you don't see a lot of separation because of the recoil, and yet there is still instability such that when you spring the pelvis, there is a wider separation. Thus, the actual damage is at times occulted with traditional static imaging. The addition of stress testing to repeat x-ray has identified false negatives, which were then elevated to a diagnosis of surgical instability. One of the potential roles of orthopedic manual physical therapy in the chronic pubic joint dysfunction, traumatic symphyseal diastasis, and obstetric pubic symphyseal diastasis populations is to perform stress tests while palpating the pubic joint width and the verticality, and to discern if significant palpable widening or vertical shift occurs. If moderate to severe instability is identified, then referral for stress imaging is indicated, as would be referral to a orthopedic trauma specialist. Otherwise, if it does not occur, then rehabilitation would continue. And so what I'm suggesting is that manual physical therapists who treat persons with the appearance of pelvic joint instability should perform the same gapping tests, the same spring tests, while palpating the pubic joint. So they could palpate the top of the pubic bones. There should usually be a little bit of a divot there, and they can palpate one side and then the other, and then perform the stress test, see if there's alteration vertically, and they can then switch sides and do the same thing. In the case of an instability, you may see you may feel a significant shift under your fingers. You can also put your finger against the fibrocartilage, which is I'm going to reverse this, which is the fibrocartilage that connects the two pubic bones here. You can put your finger there. Sometimes it takes a pinky finger, or you just might lay your finger across that. And then when you do the spring test, if there's separation, you'll feel a distinct step off. So we should be able to do that manually, and there is in fact a population who is out there that still suffers because when they looked at the x-ray, there wasn't the separation, and that was due to recoil, and yet these people are living significant lives of disability because they are underdiagnosed. So the manual physical therapy testing does have some application. And I'm going to talk a little bit about diastasis theory and then diastasis recovery. Now it appears that in preparation for birth, there's a normative spreading of the pelvic joints that happens as the baby grows. But there is an upper limit where the spreading of the pelvic joints cannot continue. It reaches an upper limit. And at that point, the upper pubic joints and the anterior and upper sacroiliac joints are maximally compressed, which restricts any further gain in motion, such that at the onset of pubic diastasis, of obstetric pubic symphyseal diastasis, the symphysis ruptures and separates which then allows a completely different trajectory of the pelvic bones. Now, and I call it a novel cam-like trajectory, which is now primarily constrained to the transverse plane. Now, when that happens, the iliac bones compress behind the true sacroiliac joint and basically form a new articulation. You can see that, and I will demonstrate what I'm speaking of. You can see that in this x-ray and in this one. You can see the gapping where the sacroiliac joint is. Now the space below it is actually behind the true SI joint. It's called the retroarticular space. But what happens is that, if you see the white arrow here, the ilia move in the transverse plane, they move posteriorly, and you get compression of ilium against the sacrum in a part of the joint that actually normally is separated, and you get distraction in the joint which is normatively compressed. So if I show you that with a pelvic model. As the baby is growing inside the pelvis undergoes some spreading in the lower part to allow delivery and to allow space for that expanding growth. Ultimately, you get to a point where you have compression at the upper pubic joint and compression at the upper SI joint. Okay, you can see the brim of the pelvis coming in, and you can see the sit bones spread out, and they also come forward a bit. Sacrum actually also goes backward. So you have an increase in the dimension front to back and side to side. However, you get to a limit where that simply cannot happen anymore. And so basically this is happening in this direction, and you get to a compressive point where it can't happen anymore. At that point, the pube ruptures, and then the ilia fold out and back. They move out and back, and that's what this x-ray shows here, where the ilia is slid back. And on this x-ray, it shows something similarly. This is on the right side, and you can see that this hemipelvis, you can see the black arrow, has shifted backwards, and you can see on this side that it is compressing behind the joint, whereas in the true joint up here, you see the two white arrows, it shows a separation of the sacroiliac joint. This is part one. We will stop right here.